I think the oral SERDs and related compounds, Protax, CERAN, SERMs, et cetera, is a pretty exciting field. Really, our advances in ER-positive breast cancer have been in combination agents recently, mTOR inhibitors, CDK4/6 inhibitors, PI3 inhibitors, but we haven't had a new endocrine backbone since fulvestrant in the 1990s. So having these new endocrine backbones is really quite exciting. Oral SERDs work by degrading the estrogen receptor, so kind of flagging that estrogen receptor for degradation in the cell and getting rid of that signal for the cancer cells to grow and divide. There is a host of them in development. We've seen a total of 4 randomized trials. The first one was Elacestrant, and this drug is now FDA approved for patients that have ESR1 mutations. We saw 2 negative studies with oral SERDs, smaller studies out of ESMO last year. And then we've also seen positive data from Camizestrant, an oral SERD randomized against fulvestrant. Not FDA approved yet, but in confirmatory trials. So where are SERDs going? I think that's a really complicated question. So certainly they're going post CDK4/6 in the second line. So you can think of that as kind of replacing fulvestrant. We know fulvestrant has some issues and doesn't have as good activity after CDK4/6 inhibitors. There's a lot of trials looking at SERDs in combination with CDK4/6 inhibitor in the first line setting, and there are adjuvant SERDs, so large trials enrolling patients for adjuvant therapy. And there's really 2 flavors of those, either upfront, so SERD versus aromatase inhibitor, which is our standard treatment right now, or this switch strategy where patients may be on the aromatase inhibitor for a couple of years and then switch to a SERD. So a lot of data being generated, and I think we will see novel endocrine agents even in earlier settings the next several years.